Hi everyone, so I'm Rebecca Shaw. So I'm a haematology registrar in Liverpool, and I'm also a clinical research fellow working at the University of Liverpool. So the topic for our webinar tonight is called TTP, the ticking time bomb. So I'm going to start off by discussing a real life case with you, and then we'll talk more about what TTP is in more detail later on. So it's late evening and you receive a request for a blue light ambulance. So this is the kind of terminology that you might be hearing on the ward. The information that you receive is that this is a 24-year-old female. Platelet count is 4 and she is anemic. You're told that she has a suspected diagnosis of TTP. The staff from the ward have mentioned that she does have, or she has had, some minor speech disturbance. They think that it probably wasn't that bad. They think it's got better now. But this is something that they've mentioned to you during the handover. And you're told that she requires urgent transfer to a specialist centre for plasma exchange treatment. So there's a few features of this case that I want you to try and keep in your mind. It's obviously a young patient. She's got a very low platelet count. She's anemic. And also the minor speech disturbance as well. 1 hour later, you arrive at the referring hospital and you're told the patient has just had a generalized seizure. As you arrive, she is with the whole anaesthetic team and she is about to be intubated. Once the team have stabilized the patient, transfer the patient to their nearest TTP Specialist Centre, which in the northwest, that would be Liverpool. And you transfer her with the anaesthetic escort. The patient is taken directly to the intensive care unit where the critical care team and the haematology team are all there waiting for her. She is commenced urgently on plasma exchange pretty much as soon as she arrives and it's safely possible. 4 hours later, the patient has a cardiac arrest. She is resuscitated and she's recommenced back on the plasma exchange treatment. Unfortunately, despite the best efforts of the team and all the treatment they could give her, she has multiple further cardiac arrests, and unfortunately, she dies at 2:21 in the morning from acute TTP. So why do I need to know about TTP? So TTP is the abbreviation for thrombotic thrombocytopenic purpura. Now, that's quite a mouthful, so we tend to abbreviate it to TTP for ease. But if you have a little look into the name, it can tell you a lot of information about the condition itself. So thrombotic, essentially, these patients form small blood clots around the body. And again, we'll talk about that in more detail in a bit. Thrombocytopenic, they have a very low platelet count. And purpura to describe the pattern of bruising and the rash that can appear when these patients are acutely unwell. So TTP is a rare but potentially fatal condition. Now, historically, most of these patients would have died from the condition. There is a 90% mortality if they are left untreated. However, even with the gold standard and the best treatments that we have available, the mortality still remains at around 10 to 20%, and it has done for around the last 20 years. TTP is a rapidly progressive condition, and it's also lifelong. So we look after these patients long term, and we know that around 30 to 50% of these patients will relapse during their lifetime. It's not just a one-off episode. This can be multiple episodes from a known patient as well. So let's have a look about why does this happen? Why does TTP occur? So we have 2 diagrams here. Now, if you look at the top diagram, this is depicting what happens in the normal circulation of a healthy person. You have the endothelial cell lining. And what happens in the normal circulation is that when you get von Willebrand factor, which is a clotting factor, this can build up into strings, but it is actually cut down by an enzyme called ADAMTS13. So I like to think of the ADAMTS13 as basically like a tiny pair of scissors. So when you get these strings of von Willebrand, it's actually chopping it down into smaller pieces. And this is just happening, the ADAMTS13 will be there and present at around 60 to 100% in a normal healthy person. However, in TTP, these patients have a very severe deficiency of the ADAMTS13 enzyme. Now, what this means is that you don't have these scissors basically chopping away at the von Willebrands, and you get these very long strings or multimers of the von Willebrand factor that then attaches platelets onto it, and you get aggregates of platelets as well. So you can see in the bottom picture, long strings of the green von Willebrand factor, and all the platelets are then bound onto and aggregate onto the long von Willebrand factor. This basically causes lots of very small blood clots throughout the system of the patient, and these can occur anywhere in the body, but they tend to occur where there is high shear stress in the blood vessels, and we'll talk about the organs where we tend to see it more frequently in the next slides. So you can see here, this was where the thrombotic element comes along, so they're getting these lots of small blood clots forming. Now I've highlighted in red here on the side thrombocytopenia and hemolytic anemia. Now actually, these patients, so although they have a low platelet count, the platelets are actually present in the circulation, but they're all in the wrong place. You can see they're all attached onto these von Willebrand strings. When you take the blood of these patients, their platelet count tends to be in single figures. These patients also develop what we call a microangiopathic hemolytic anemia, which again is another mouthful, but just to break that down more simply, you can see the red arrow across the bottom is the direction of blood flow. Because all these small clots are forming within the small blood vessels, when the red blood cells try and pass through these blood vessels, they actually get broken down into fragments and they hemolyze. So you will see a specific type of hemolytic anemia on these blood tests of the patients as well. TTP historically used to be thought of as a pentad of features. So we used to think of it as low platelets, the anemia, fever, acute kidney injury, and neurological symptoms. So it used to be thought of as all 5 of those symptoms, but actually we know now that TTP is far more varied than this in its presentation. And actually, you should be considering a diagnosis of TTP just with a low platelet count and a hemolytic anemia alone when you don't have any other obvious cause for it. So I'll talk in a little bit more detail about the pathophysiology of TTP. So we've mentioned that the patients have an ADAMTS13 deficiency, so a lack of this enzyme that is cutting down the von Willebrand factor. In TTP patients, we see that when we measure their ADAMTS13 activity, we find it to be less than 10%. And I mentioned briefly earlier that in a normal healthy person, we would expect their ADAMTS13 to be somewhere in the region of 60 to 100%. There are different types of TTP, but by far the most common type of TTP that we see is where the patients actually develop antibodies to the ADAMTS13 enzyme. Now, this is called immune TTP, and this is probably 90 to 95% of cases that we see. There is a small number of patients that actually have what we call congenital TTP. This is basically where they have an abnormal gene, so they are not producing a normal ADAMTS13 enzyme as a result of an abnormal gene. As we discussed before, because of the lack of this enzyme, the patients develop multiple small blood clots or microthrombi throughout the body. Now, I mentioned this tends to be in the high shear stress areas, and the organs that are mostly affected in TTP patients are the heart, the kidneys, and the brain. And obviously they will get different symptoms depending on which organ is impacted at the time. From the heart point of view, it's extremely common for these patients to have elevated troponin when they're acutely unwell. It's quite unusual for us to see patients with chest pain, for example. But that's really because unlike with myocardial infarct, they haven't got a massive clot forming. It tends to be these multiple smaller clots all the way through the body. Kidneys, we see it's pretty common for us to see an acute kidney injury. However, this is generally in the mild to moderate region, and it doesn't tend to be as a severe kidney injury as with some other conditions. And then brain, and this is probably the most common organ that we see impacted in terms of symptoms. The patients can develop a huge variety of neurological symptoms, and this can be something as minor as a headache right the way through to a coma. And again, we'll talk about this a bit more later on. So let's have a little look about who is affected in terms of TTP. So I guess the main take-home message is actually that TTP can affect any person at any age. We tend to see a predominance in female patients more than male patients, about 2/3 to 1/3, and this is quite similar to other autoimmune conditions. The most common age range would be the 30 to 50 year age bracket, but within our specialist centre, we advise on anything from paediatric cases right the way through to we've had patients up to 80 years old as well. So it's a really varied range there. There is also it's slightly more common within the Black ethnicity groups. And we see in the UK around 100 to 150 cases per year. So I'm going to briefly mention some of the risk factors for TTP. Now, for a lot of our patients who are newly diagnosed with TTP, it tends to not always be obvious what the trigger has been. We don't always know exactly what has triggered it to cause at that point in time. The risk factors, when we think about risk factors as well, though, it's not just for an acute diagnosis, it's also risk factors that we bear in mind for our patients that we already know have TTP. These things we monitor in terms of risk of relapse of their TTP as well. So the sorts of things that we'll keep a really close eye on are different types of infections. And obviously we've been watching like a hawk during the COVID-19 pandemic, really keeping an eye on all our patients, because obviously this was a new disease, so we didn't really know how it might affect our patients at in the early days. Pregnancy, this is a really interesting one. So actually the patients that are more likely to present in pregnancy are the congenital TTPs. So that, yeah, they're the ones that tend to be more likely to present with pregnancy. Surgery or other medical procedures, again, can be a risk factor. And we know also that certain types of medications can be associated with the development of TTP or a similar like syndrome. So again, we have to be quite cautious about the kinds of medications that our patients are taking as well. So I'm going to just talk in a little bit more detail about the clinical features of TTP. So we've talked already about kidney impairment and the fact that this tends not to be very severe, although there is, again, can be a range, it is varied. The patients obviously have this extremely low platelet count, and as a result, you can get bleeding and bruising symptoms, and the typical bruising pattern being the purpura that is mentioned in the name TTP. And again, these neurological signs and symptoms right the way through from very mild symptoms, and headache, for example, is the sort of thing that patient might not even mention to you unless you specifically ask about that. And it's extremely common once you start specifically asking about this symptom. And then right the way through to seizures, which we saw in the very sad case at the beginning, and coma and reduced conscious level. So I'm just taking you on this slide to have a little look under the microscope. So as haematologists, we love to have a look at the blood film, and imagine you're looking down the microscope here. You can see the red cells, I don't know if you can see my arrow, but the round cells are the red cells. Now, we know that the two predominant features that we talked about were thrombocytopenia and hemolytic anemia. The thrombocytopenia is basically seen because there's a lack of platelets, which are the very small purple dots. And then this microangiopathic hemolytic anemia, that's what I was talking about when the red cells move through the circulation and then they're broken down into fragments. So you actually see these fragments of red cells actually appearing on the blood film, and that's what the black arrows are actually pointing to. So these are broken down, physically broken down fragments of red cells. And so this is another feature which alerts us to the possible diagnosis of TTP. So just to sort of highlight again the symptoms that you want to look for when you're seeing a patient with suspected TTP or with a known TTP. This top left picture is the purpura that I've been talking about, and then the bleeding and bruising, the other bleeding and bruising symptoms can appear from epistaxis to bleeding gums, and these are the kinds of things that you need to look out for. And then again, just talking about the neurological symptoms. So again, completely varied between different patients. They can be anything from the top left is trying to depict confusion, and again can be quite subtle. Headaches you need to mention, you need to ask about specifically. And then in the top right hand corner, this man is supposed to be very angry. Some of the patients, as a result of the small blood clots that are forming in the brain, actually can become very agitated, and that's another sign, another neurological symptom. And it sometimes is to the point where they have to be intubated in order to carry on with the plasma exchange treatment as well. So I want to just talk in a bit more detail about warning signs. So if we think back to the case that I mentioned of the 24-year-old girl right at the beginning, there was a warning sign even from very, very early on with this patient. So in the handover, the staff had mentioned some minor speech disturbance. Now, when it comes to a suspected TTP diagnosis, any sort of speech disturbance, any sort of neurological symptom or sign is not minor. It's a major warning sign. It's a major sign that this patient, impending deterioration of the patient. It's something that basically means they need to get treatment as soon as possible. They need to be transferred to the specialist centre. There is no time to wait, basically, because we so often see a very rapid downhill trajectory for these patients once they've had those initial neurological signs. I've mentioned a few of these already. So the speech disturbance was in the initial case. Seizure, confusion, blurred vision is another one. Limb weakness or numbness, it might be coming and going, but if it's been there at any point, that is a warning sign. And also drowsiness, sleepiness, reduced conscious level. So I'm just going to move on now to one of our patients and her husband and just their perspective, talking about right the way through to when the symptoms first developed and their journey through to coming to the specialist centre as well. So I'll just go on to the next slide and play this video for you.
Hi, my name's Jane. I was diagnosed with TTP in June 2016.
Hi, my name's Mark, Jane's husband, and together we're just going to try and run through the timeline of what happened from Jane first feeling ill to her being admitted to Liverpool Royal, to the ICU in approximately the 24th of June 2016?
It all began, I started noticing blood in my urine. I went to my GP and they thought that maybe I've got a urine infection, so they gave me some antibiotics. Took my antibiotics, still had blood in my urine, there was no improvement. Also started noticing that I was getting bruises on my legs, behind my knees, bruises where I hadn't banged myself or anything, and I was also feeling quite tired and lethargic. This went on for approximately 10 days. I went back to my GP, at which point they said maybe that I had some problems with kidney stones and they were referring me on to neurology. They also felt that maybe I had problems with earwax. As I said, I felt a bit dizzy. They suggested at this point that I had a blood test and to go and see the receptionist downstairs and to book myself in for an appointment. I went downstairs and asked the receptionist for an appointment. They told me that I could have one in a week's time. Luckily, probably through some of my own basic knowledge from being a nurse, I felt that something wasn't right with the amount of bruises that were appearing, and I had one bruise that appeared while I was sat in the surgery. I said that I felt I needed them done urgently. So I went to the hospital, to the path lab, and had these done.
So this is about 2 days before you're getting admitted to Liverpool now, isn't it?
Yeah.
That's where we are now on the timeline.
Yeah. At this, I then went home that evening, prepare some dinner, put some roast chicken in the oven and peel some potatoes, put all of that on. Went upstairs to do something and was so exhausted I just lay on the bed and didn't move from there.
So at this particular point, I was out with my son doing some training walks up in the lakes. I was going to be doing the following Saturday a big event, a walking event up in the fell. So I was out training and I got back into the house. Beautiful summer's evening, middle of June, around about 9:30 at night. And there was smoke coming out of the oven. The chicken was well done by this time, so I turned it off and went up to find Jane, very, very tired, lying on top of the bed. She said she was feeling unwell and very tired, on top of the conditions Jane's already described. And around about that time when I was talking to Jane, we got a phone call from Furness General Hospital, who said that the blood test that Jane had had earlier that day had come back with extremely low levels in many cases. So they'd like me to bring Jane right up to the hospital. They suggested Jane didn't drive, and so we went up to the hospital. And when we arrived at the hospital, they showed us the results and said that they'd like to admit to the hospital. And at that particular time, they talked about Jane having a blood transfusion the following day. So maybe you can talk, Jane, about what happened during the next day or so.
Yeah, the following morning, I just vaguely remember sort of being hooked up to a machine and having a blood transfusion given, and them just taking more blood, doing more tests, things like that. Didn't really know what was going on at this point. Eventually a haematologist, Dr. Machita, came to see me and said that he was concerned about my bloods and he wanted to have another look at them. He didn't know what was going on with them. There was a condition that he thought there may be, but he didn't know. So all that was going through my mind at this point was, did I have cancer? Did I have leukemia? I just really didn't know. Still feeling very tired. But there was no sort of urgency about my situation from the staff from the hospital or anything at this point. Later on that evening, I think Mark had come to visit me and Dr. Machita had come back again and said that he felt that I might have some rare condition called TTP. He wanted to send me to Liverpool. He said that it's very rare and that he'd rather send me there, have egg on his face and it not be TTP than leave me where I was.
Yeah, I arrived at the hospital after work at around about 4 o'clock in the afternoon, and that's pretty much the time that Jane was referring to, where Dr. Machita, the haematologist, was sending people back in to get sample after sample. I'm sure what he was doing was trying to double confirm his assessment. While I was sat there with Jane by this time, I mean, by the way, the timeline on this is the day that we went to Liverpool. We arrived at Liverpool around about 11 o'clock at night, so this is about 4:30 that afternoon. While I was sat there talking to Jane, I can only describe what had happened is she started to lose the ability to talk. One side of her face dropped, and it looked to me as if she had had a stroke. We called one of the nurses and doctors in, who basically said, look, her face then returned to normal and she was able to talk, not perfectly, but it did. And we were assured that there was nothing to worry about. We're still trying to make an assessment, but it looks as though you're going to be going to Liverpool. So probably around about 6 o'clock, the assessment was made that the words were, it needed to be blues and twos directly down to Liverpool. And that assessment was made, I would say, no later than 6 o'clock at night. You know, Jane was made comfortable whilst we were waiting for the ambulance. And I had to go repeatedly to the ward reception, and bearing in mind that there would have been a shift handover during this time as well. And I think that the handover happened, and it wasn't until the new shift came on that I was, after repeatedly saying, look, this is supposed to be blues and twos. Jane's condition hadn't deteriorated by this time, but I was getting very, very concerned that somebody had made an assessment that it needed to be blues and twos down to Liverpool, and despite constantly asking every half an hour, the ambulance just didn't arrive. It didn't feel right, but we were assured that it was nothing to worry about. Eventually the ambulance turned up at around about 9 o'clock at night. Jane was put into the ambulance. I had my car there, so the ambulance set off, and I set off independently to Liverpool Royal, where they explained that Jane was being taken.
Yeah, the ambulance crew were really, really friendly, really, really nice, very reassuring. Asked me about what, if they knew what was wrong with me. They didn't really know much about the condition. I didn't know anything about the condition. They made me feel very reassured in the ambulance, but they didn't have the knowledge of the condition, and I do remember them asking me about it. I can't really say anything more than that on that. I just remember then eventually getting to Liverpool. There was a bit of confusion where you went into Liverpool, into which department. I remember that. And from then it all seems a bit vague to me after that.
So I actually arrived in the car park outside Liverpool as they were taking Jane out of the ambulance. So, we had pretty much similar journeys in terms of time. Of course, I was told that I couldn't leave my car there, so luckily there was a parking space outside, so I went out, but they told me that Jane was heading towards the ICU. So I got up to the ICU. I was welcomed by a fantastic team there. I sat down next to Jane, and we were talking through the procedure that Jane was going to go through by going through some plasma exchange procedure, all very, very new to us, and we had no idea what it was all about, but it was very reassuring. So I guess that Jane had first got into ICU around about 11:30, 12 o'clock at night, something like that. Certainly within 30 to 60 minutes of Jane arriving, she had her first seizure. It was frightening for me. I just had to leave and go into the waiting room and let the team there just take care of it. They settled Jane down, but at that particular point, she was put into an induced coma at that particular time. I spent the night in the waiting room, and I was awoken at 5 o'clock in the morning when Jane had a second seizure, and at that particular point I was advised by the medical staff there to go and ask Jane's parents to come, because things didn't look particularly good at that particular point in time. So that's pretty much our timeline.
Yeah. And I think it's all brought home to us is that people do need to be educated about this. Professionals, from GPs to hospital staff to paramedics, because there's so little known about this condition. I was really, really fortunate that a haematologist at our local hospital in Barrow-in-Furness had seen this condition once or twice before in his career. He's literally just retired, so he's had a long career behind him. But I was fortunate enough that he picked up the blood results and platelet count and everything, and took that decision to send me to Liverpool to get treated. It is just so important. Time is of the essence in this illness, and you need to be treated straight away. I'm one of the fortunate ones that's here today to be able to tell our story and hopefully help in the education of TTP. Thank you.
Thanks very much.
Thank you.
So I just want to say a huge thank you to Jane and Mark for sharing what must have been an extremely stressful time for them, but I think it just highlights such important points coming from their view as well. So their story actually brings us on really well to how is acute TTP treated. So I mentioned at the start that despite there have been significant improvements, actually the mortality does still remain 10 to 20%. There are national guidelines in the UK for the emergency management of TTP. And these advise that plasma exchange treatment is given within 4 to 8 hours of suspected TTP diagnosis. Also within the emergency management of a TTP is that we give steroids. Now, because we know that most of the TTP cases are immune driven or caused by antibodies, the idea behind steroids is to suppress the immune system. Now with plasma exchange, I've got a diagram of this a bit later on, but the idea is that you replace the patient's plasma with fresh donor plasma, so that you're giving them ADAMTS13 enzyme, which is in the donor plasma, but also you're removing their plasma and removing their antibodies as well. So this is just a figure to explain what happens with plasma exchange. So plasma exchange can only be done within specialist centres, which is why we need the patients to be transferred as soon as possible. The plasma exchange is basically a machine, and it can be done in emergency through 2 large bore cannulas in each antecubital fossa. However, generally, because we're transferring these patients directly to an intensive care unit, they tend to get a line either put in the neck or the groin. So it can be done either way in an emergency. What happens is that you're taking the patient's blood out of their body, it goes through a pump and it's separated. So you're separating them into the red cells, the white cells, and the plasma. The waste plasma is their patient's plasma that you want to get rid of, and the replacement fluid, in this case replacement plasma or octoplas, which is like a solvent detergent or cleaned plasma, is then replaced back into the patient. So the volume is replaced, and then the patient's own red cells and white cells along with the donor plasma go back into the body. These are some amazing pictures actually that I got from the plasma exchange team. So there are a team of nurses that come, and they're on call for the whole region. You can see basically the very, very dark browny red coloured plasma is an acute TTP patient's plasma that has been removed. And if you compare that in the picture on the left hand side to the more yellowy coloured plasma is the fresh donor plasma, which is what your plasma should look like, and that's what's being infused back into the patient as replacement. For acute TTP patients, we actually tend to need around 25 to 30 bags for a acute patient diagnosed, bags of plasma that is. So it's an awful lot, and when these patients, when TTP patients arrive at the specialist centre, this has actually been an enormous team effort even just to get to this point. So you obviously have the team in the referring centre, you have the ambulance service that are getting the patient across to the specialist centre where they can get the urgent treatment that they need. Once they arrive in the specialist centre, you've got everyone from the transfusion staff defrosting the plasma to get that ready. You've got the porters that are ferrying the plasma back and forward. You've got the plasma exchange nurse that has to often, like I said, come from all the way around the region, as well as obviously the critical care and the haematology team as well. So that it's a huge team effort to make sure these patients get to the right place at the right time. So just having a little think about the time to plasma exchange. So we know that from the national guidelines, this should be within 4 to 8 hours of diagnosis. I'm just going to tell you a little bit about a piece of work I've been involved with a group called HaemStar. So this is a group of specialist haematology trainees that focus on promoting research within haematology. We did basically a UK-wide review of 148 TTP patients treated in 80 different UK hospitals. And we found that the median time to plasma exchange from first presentation was actually 15 hours. So this is significantly longer than what is suggested in the guidelines. We tried to sort of unpick what might be the main reasons behind this, and it is, as you can imagine, there's plenty of factors that can be involved. One of the main things that was highlighted was possibly a delay in actually recognizing or diagnosing it in the first place, all the way through to delays in transfer. It was definitely multifactorial. Just to mention a little bit more about some of the other treatments that we have available for TTP. So in an emergency, the patients we've mentioned plasma exchange, we've mentioned steroids to suppress the immune system, and also patients will receive a drug called rituximab, which you might be familiar in because it's used in a lot of cancer treatments. So rituximab is basically a anti-CD20 monoclonal antibody, and so it's targeting the B cells, it's targeting the cells that produce antibodies. So again, the whole idea is that you stop the patients producing these abnormal antibodies to the ADAMTS13. The rituximab although it hasn't been shown to improve mortality, it does reduce the risk of relapse within patients. With, I suppose, one of the downsides being it does take a little bit of time to work, so it's not immediate, so it's not the answer to everything. One of the newer drugs that we have available is called caplacizumab, that's been trialed in the phase 2 and phase 3 clinical trial and is now been approved for use as well. So caplacizumab is what we call a nanobody, so it's actually a fragment of an immunoglobulin. And in the studies and also in the real world data that myself and Dr. Dutt have published, we have shown that the caplacizumab drug actually reduces the time to platelet recovery. So these patients are going from single figure to normal platelet count in a much quicker time than if they didn't have the drug. But also in addition to this, it's shown a reduction in the length of time that patients need to stay on plasma exchange and a reduction in the length of hospital stay. So this all looks very promising. So I just wanted to show a slide just to focus a little bit on pre-transfer, so things to think about before the patient is transferred to a specialist centre. Obviously, the main priority is to get this patient transferred both as quickly and as safely as possible to the right place. A couple of things to bear in mind. So we do sometimes advise to administer a plasma infusion before the patient is transferred, but this is just a holding measure. So essentially, when I say plasma infusion, this is different to plasma exchange. Plasma infusion would just be similar to, say, when you just transfuse a patient a bag of blood, for example, but instead you're giving them plasma. So you're giving them something, but you're not taking anything away, which is how it's different to plasma exchange. And again, this is just a holding measure. This is not the gold standard treatment. We must make sure that an ADAMTS13 activity blood has been taken prior to giving any donor plasma. So ADAMTS13 activity is how we're diagnosing TTP. Obviously, if you're giving a patient plasma from another patient, if you then measure the ADAMTS13 after that, you're probably just measuring the ADAMTS13 from the donor rather than the patient themselves. We do often suggest that actually the ADAMTS13 sample comes from the referring trust in the ambulance to the specialist centre, and that way we can direct it right to the specialist coagulation lab where we know it needs to go. And that way we know that we've got our hands on the sample, because these are very precious. And I did mention before about an anaesthetic review. And again, in terms of the rapid deterioration that we often see, we advise that these patients do have an anaesthetic review prior to being transferred. This is just our suspected TTP transfer protocol. So it's highlighting a lot of the points that we've already talked about, that TTP is life-threatening, high risk of sudden deterioration, and the national guidelines of plasma exchange within 4 to 8 hours. It's got advice on emergency ambulance transfer and recommending an anaesthetic escort who is competent in intubation, and as well as some contact numbers and where to bring the patient when they get to the Royal. Okay. So a slide to mention actually why are we treating these patients in specialist centres. So there's lots of reasons for this. I've mentioned already that plasma exchange cannot be delivered in all centres, and we know that this is the emergency treatment that is required. So that's one reason. Another reason is that not all hospitals actually measure the ADAMTS13 activity, which is how we diagnose. Whereas in specialist centres, we have 24/7 availability to measure the ADAMTS13 activity. In the specialist centre, we also have access to novel therapies. So the capizumab drug that I mentioned earlier, we know that we can get that very quickly for any patients that require it, whereas it would be much more difficult to get hold of in some of the smaller hospitals. We have plenty of research and trial opportunities available for patients, and in this way we have access to newer therapies as well through this route. And we also have long-term follow-up and support. So we've briefly touched on the fact that TTP is not just a one-off diagnosis. There is the potential for relapse, but also we're learning more and more about the longer-term symptoms that TTP patients can face. And for this reason, it's really important to provide the long-term follow-up and support and regular monitoring of their blood tests and their ADAMTS13 levels. And on top of all of this, we know that the care for patients is improved when we focus expertise into specialist centres. Some recent updates to tell you about. So actually NHS England have commissioned new TTP specialist centres around the UK. Originally, the only TTP specialist centres that existed were UCL down in London and then the Royal in Liverpool. But I believe, Tina might be able to correct me on this, but I believe there are at least 5 new centres that are due to be open as TTP centres around the UK. And this is basically, we want patients to be as close as possible to a specialist centre and not have to travel such distances. And in terms of the Northwest Ambulance Service, the recommendation and agreement is for suspected TTP patients to be transferred via a Category 2 ambulance. So my understanding of this is that this would be along the same lines of if a patient was experiencing an MI or a stroke, for example. So it would be Category 2. So I just want to finish off by summarising what we've talked about this evening. So TTP, the ticking time bomb, TTP is a rare condition, but it's so important to know about because of the potential for high fatalities and the seriousness of the condition. Once TTP is suspected, the patients require urgent transfer to the nearest TTP specialist centre. The first line emergency management is with plasma exchange and steroids. And just to end on the phrase, so with TTP, time matters. Thank you. And if there's any questions, we'd be happy to address them.
Thank you very much indeed, Dr. Rebecca and Dr. Tina. Dr. Tina has been through most of the questions and answered them live online, which is amazing. Honestly, you two can definitely come again. It was been fabulous. But Tina, you've done an amazing job. I've just looked at the questions and answers, and you've done most of them, which was amazing. I like it. Right, some questions and answers. Let me get these ready for you. Do you want to pick which questions are best to answer? Can you see the questions and answers on screen, Rebecca?
Yeah, I've tried to keep up. I'm just delighted that there've been so many really important and really good questions. I think I've improved my typing speed in 20 minutes. There've been some really, really good questions, and I'm sorry if I've missed some of them along the way. But one of the important questions that I've just answered, which is a really great point to get across, is around the need for intubation or potential intubation on transfer. So I've mentioned in a couple of my answers that neurological symptoms are a really poor prognostic sign. And neurological symptoms suggest that the patient may deteriorate rapidly in the next 24 hours. We often see that patients are, one minute they're sitting up and the next minute they're having a seizure, or they are losing their airway. And so if patients have neurological symptoms prior to transfer, we suggest that an evaluation is carried out to see if they need intubation before they are put in the ambulance. So this is something that's quite alien, because normally we wouldn't intubate somebody unless there was cardiorespiratory compromise. However, because neurological signs are such a poor prognostic marker, what we don't want, and what we have had, is some very tragic and sad stories where patients have deteriorated in the ambulance, have become very agitated, very confused, and this has led to a poor outcome, and obviously a really poor experience for everybody, both the paramedics, the patient, and family. So this is something we stipulate on the referral form. So at the time when the ambulance is called to carry out an emergency transfer, the first thing we recommend is a critical care evaluation to make sure that the patient is safe for transfer. And if the patient requires intubation, to intubate pre-transfer. And also we advise that there's an anaesthetic escort with the patient. So that's something that's really, really important. I haven't looked at the chat now, so you're going to have to give me a heads up, or Rebecca, if you want to answer some of the questions.
I'm just I don't even know where to start. There's so many.
There is, and they're moving really quickly. Ross has just said, "Can we get some more webinars, please, with Rebecca and Tina?" I think that's it.
I would definitely come again. It's absolutely amazing audience. Really, really good. It's you know, and I said right at the beginning, actually, it's such a critical part of the chain. I think, you know, Rebecca's conveyed that time is really of the essence for these patients. You know, really moving story from Jane and Mark, but we're talking about minutes here, where, you know, a patient can be apparently well, and we've done, you know, audits where we've looked at news and that kind of thing. A patient can have a news of 0, and then within the next 10 minutes require crash intubation, and is fighting for their life. So, and
I think, and I was going to say, just the other thing as well is, sometimes I feel as though maybe the referring hospitals or even on transfer, sometimes they see this, sometimes they don't, because we only might see it once they get to the specialist centre. So I think this is why we're trying to get that message out, because, you know, we're worried sometimes they might see the patients leave and then they're fine, but they don't know what's happened to the patient after they've left that ward, kind of thing.
And I think what the audience have really picked up on is this is a real challenge for rare disease, because these are not, everybody knows if you have a heart attack, if you have a stroke, you know, it's a door to needle time. We've got to move really fast. When you say TTP, no one, you know, really has potentially ever heard of it, or no one has that familiarity. And so, you know, what we generally try to say is, if you hear those 3 letters, TTP, just go with it, that it's an emergency, and then, you know, the various sort of other specialist links within that chain will hopefully fall into place. But we've just got to get the patient to treatment. If patients don't get treatment, it's really simple, they die. If patients get treatment, that mortality of 100% falls to about 20%. So, you know, they're really sort of battling against the odds at the time of diagnosis. But actually, you know, what ITU data shows is that these patients go into ITU, but unlike other groups of ITU patients, they come out because the treatment works. So if we can get them treatment, you know, the chances are they will survive and go on to, you know, live a much longer life. There was a couple of questions I was conscious of about the specialist centres. So at the moment, Liverpool and UCL in London are NHS England commissioned centres. This has been a journey because there were never any TTP centres, and patients, unfortunately, would die because they would present in hospitals where the workforce weren't really sure what the diagnosis was. Plasma exchange wasn't widely available, so it was only available in some hospitals, whereas over the last 5 years we've really pioneered and championed sort of that there should be specialist centres, and that, you know, this should be the aim, is getting the patient to a specialist centre where there's a team that knows what to do. You've got all of the different sort of components of the centre that are required for the patient to receive treatment. So this year there'll be a total of 8 to 10 centres in the UK. So hopefully that means that the map's covered, that within sort of a 2-hour sort of travel radius, patients will be able to get to a centre. I can say that Liverpool serves the Northwest, and that's Manchester and sort of North Wales and Blackpool and Cumbria, so fairly wide geographic footprint. I suspect that other areas that will sort of bid for centres will be places like Sheffield, Newcastle, Birmingham, Cambridge. My geography is quite poor the further down we go, but you know, I very much hope Bristol, that you know, wherever patients are, it won't be a postcode lottery. They'll be able to access the services they need.
Excellent. Thank you, Dr. Tina. I've just got a quick question that's popped up from Chris, which might be relevant for a lot of people still on with us tonight. In terms of gross presentation, what would be the difference in presentation between TTP and DIC? Is the difference microclots in TTP?
Such good questions.
I know, I just
so impressed with the quality of the questions. I mean, I wish I could get this out of, apart from Rebecca, some of my registrars. Rebecca, do you want to answer that, or?
Yeah, so actually that was, you've literally picked out the question I was going to go to next, actually. So Chris, yeah, that's such a great question. So there are definitely some similarities between TTP and DIC, which for those who aren't familiar, DIC is disseminated intravascular coagulation. And so I would say the main difference in terms of when you have a patient in front of you and the blood tests in front of you, with TTP, we tend to find that their clotting screen is normal. With DIC, they have a very typical pattern on their clotting screen. So they tend to have very prolonged prothrombin time, or PT, also can have a prolonged APTT, and also a very low fibrinogen. So there is a scoring for DIC, and again, DIC tends to come along with, for example, severe sepsis or maybe obstetric complications, but it tends to be associated with another condition as well. So I would say that's one of the major features that we look out for. But obviously there are similarities. Both these conditions, the patients can have low platelets, they can both have bleeding and bruising. So I do think it's a very pertinent, very good question to ask.
Yeah, excellent. Thank you, Chris. Yeah, it was a good question. Only because I've seen DIC in my practice, and so it'd be very good to try and differentiate. Got another quick question from Ian. What would be the correct way to hand this over to a potential from a potential patient to hospital staff from a frontline ambulance perspective if you're suspecting TTP? Just because some ambulance staff find it difficult to communicate with EDs at the point of handover, would they have an understanding of TTP if you were to hand it over to, say, the staff nurse or the the ED doctor, would they really understand and grasp the concept of TTP?
Yeah, so the honest answer is, in Liverpool, I would like to think that that would be the case, because we do a lot of education within the trust, and obviously we see a higher number of patients than other hospitals because we're a regional centre. I think if you were in a trust which isn't a regional centre, then it's unlikely that the ED staff will have heard of TTP unless they've dealt with one personally. What we have when we are expecting a TTP patient. So most of the patients are discussed with us, so they're referred on to us as suspected TTP. So we're expecting them. So we are actually, we're there as a kind of forward aid when the patient comes through in the ambulance. We ask for the ETA so that, on arrival, we're there to pick that patient up and to manage that patient. So I guess where the diagnosis isn't known or it's suspected, most haematologists, and I'd like to say more than 90% of haematologists will at least know what TTP is, even if they haven't dealt with one. So I would definitely hand it over as, could you speak to the haematologist as an emergency, because we think this patient may have TTP. In most cases, somebody has suspected it in a trust, and then they've made contact with a specialist team, and that's when that emergency transfer is made. So hopefully that handover will have happened to some degree. If you do have a patient and you're handing it over to another team who isn't really familiar, one of the biggest things is, don't draw the curtains around the patient. Keep your eye on the patient, because as I mentioned, one minute they're sitting up and they're talking to you, the next minute they're, sort of drop their GCS and in a real sort of emergency situation. So people often don't believe you, because we've done that where we've kind of said, this patient is really critically ill, and the team look at you and they say, but they're sat there reading the newspaper, or I've just had a very coherent conversation, and then 10 minutes later we've got all the teams in around them, and performing a crash intubation. And unless you see it, it's hard, but you never forget it once you've seen it.
Excellent. Thanks, Tina. I think the key take-home message is just get the knowledge out there and have a great understanding. I like the tip of let the on-call haematologist know that we've got a suspected TTP, because I think that would be really useful, certainly for the standby perspective, because even if it's just a phone call from ED to the haematologist to have a better understanding. Lots and lots of chat going on, and lots of circulation of knowledge. Ian's just asked a question. I'm pretty sure I know the answer to this, but if you're, for example, transferring a patient from Lancashire to Liverpool and the patient arrested en route, would best practice say continue to the specialist centre, or just divert to the nearest emergency department?
Yeah, so this is where the sort of evaluation pre-putting them into the ambulance is really, really important, because unfortunately we have had, in my time, patients who have become very unwell en route, and they've not survived the journey. So in the evaluation pre-transfer, critical care will be involved in that. Whatever the trust is, the critical care team will come and evaluate that patient, look at their presenting characteristics. If they've got neurological symptoms, they'll make an assessment. There'll then be an anaesthetic escort within the ambulance. So if there's a deterioration within the ambulance, the patient will be tubed. If despite that they go on to cardiac arrest, that will obviously be managed at that point. But the advice would be to continue to the specialist centre, because without treatment, basically they will go on to repeatedly cardiac arrest, and what they need is the plasma exchange. So if we're able to stabilize them, that's the only chance really that they will then survive. Without plasma exchange, the condition's fatal.